should be.
Let me try again.
Enable editing something.
Let me just share my full screen. That doesn't work. Is it now full screen?
Press on the button on the yellow bar on the above.
Yeah, but I can't because I'm in the.
I think this is why. Maybe you can just get. Oh, you cannot press anything. Okay.
I hope it's down. It's not on the yellow bar.
Yeah, maybe to
It's down
enable
on the
pressing
right.
anything, you should first press to allow enabling something on the yellow bar. That should be on.
But even if I try to, I'm kind of misguided. So I'm just going to share my full screen and then it should work. So now I think it's...
Yeah, perfect.
Perfect. The eagle has landed. Okay. So we were just defining biomarkers. What is a biomarker? So I think that came through. So sometimes people ask me, like, why do you do research on biomarkers for endometriosis? Why not focus on a cure for cancer? Well, I think because the accurate diagnosis of endometriosis is essential. We all see patients that based on symptoms and sometimes based on physical examination, we have a clinical suspicion for endometriosis. And I think all international guidelines agree, all gynecologists agree that the first line investigation then is a transvaginal ultrasound. Ideally, a transvaginal ultrasound done by somebody who has at least some level of expertise in performing ultrasound for endometriosis, because when in experienced hands, sensitivity and specificity can be quite high, but especially in unexperienced hands, you can miss especially deep endometriosis on ultrasound. So when we perform the ultrasound in a patient with clinical suspicion of endo, the ultrasound can be positive, and then the case is quite clear. Patient has a deep lesion, patient has an endometriotic cyst, so an endometrioma. So the patient is referred to a gynecologist or a multidisciplinary team that has some level of expertise in the treatment of extensive endometriosis, either medical, if it's infertility by ART or by surgery. The challenge is in the patient who has a negative ultrasound. So the ultrasound negative patients, because there we have this well-known diagnostic delay. Yeah? Because there is this balance we have to make between starting empirical medical treatment without performing a laparoscopy, where we go straight to ART in case of infertility, or we go for diagnostic laparoscopy to exclude endometriosis or to diagnose endometriosis. I think there's three typical groups where biomarkers could be very useful to have a better diagnosis of endometriosis. The first group is the patient that either presents with pain or infertility, where the ultrasound is negative, but it's a false negative ultrasound. So there is actually deep endometriosis. And if the ultrasound would be repeated by an experienced or an expert sonographer, you probably would have a positive finding. So there we would need, or biomarkers could be useful to flag our patients who are at high risk of having deep endometriosis. So we're looking here for a biomarker for deep endometriosis. You do your ultrasound, you don't see anything, but the test is positive, so you think, well, I might have a second look or ask a colleague for a second look because the patient likely has deep endo and I'm missing it on ultrasound. That's the first, I think, important place for a biomarker. A second one is the patient, a young girl who presents with pain, and she only has peritoneal endometriosis. So no imaging technique, either ultrasound or MRI, can visualize peritoneal endometriosis, and I don't foresee that in the near future it will be able to do so because these lesions don't have a physical thickness. So it's not a resolution problem. You can't see these lesions. So the ultrasound is negative and it's a true negative. And here a biomarker would be interesting to discriminate this patient with pain, chronic pelvic pain, based on peritoneal endometriosis from chronic pelvic pain from another cause. Another group is the patient who presents with infertility. And most examinations come back as negative. So you could say, well, this is an unexplained infertility, but the patient also has some level of pain that is suggestive for endometriosis. Again, in many of these patients with infertility and pain, they will have a positive ultrasound. They have a cyst, endometriomas. We just learned a lot about it. They have deep endo. But they can also have only peritoneal endometriosis. And we do have evidence there from the Canadian trial 1997 in the New England that removing patients to become spontaneously pregnant. So again, here, biomarker would be very interesting to find these patients in the fertility clinic who have peritoneal endometriosis who could benefit from a biomarker. So yes, we do need biomarkers for endometriosis. What research has been done, I think for anybody who is interested in biomarkers on endometriosis, this is a very good start. This is essential knowledge. This is a series of Cochrane reviews by the Australian and New Zealand groups of Louise Hull, Neil Johnson, Cindy Farquhar, and Viking Ezenblot, where they have reviewed all imaging techniques, all endometrial biomarkers, blood biomarkers, urinary biomarkers, and any combination of the previous as possible biomarkers for endometriosis. I think, long story short, when you will go through these 5 Cochrane reviews, and each of them are a lot of information, we can say that many are called but few are chosen. What I want to say is that we have many molecules that have been investigated as biomarkers for endometriosis, but none have made it to clinical practice and none are used in routine clinic today. And why is that? Because I think it's important to make a difference between a biomarker and diagnostic test. As you saw in the definitions that I used on my first slide, there is no mentioning in the definition of a biomarker of sensitivity, specificity, and diagnostic performance. This is irrelevant from biomarker point of view. For example, CA125 is a biomarker for endometriosis. What I mean is that, yes, on average, CA125 is higher in patients with endometriosis. And this is a case here from our own hospital, but it's very similar in other data sets. When you look at patients with endometriosis, it's more common or more often that in patients with endometriosis, you will see an elevation of CA125. However, the vast majority of patients with endometriosis have levels of CA125 in the same range as control patients. And so whatever cutoff you're using, very often you either will miss patients with CA125 if your threshold is too high, you will miss patients with endometriosis, and vice versa. If your threshold is too low, you will tell many patients who actually don't have endo that they could have endometriosis. This has been reviewed, and this is extracts from the Cochrane series that I showed to you. These are a few tests, few studies on CA125. When you put your threshold at 16 units per ml, you see a very low sensitivity at 50%. So that's the chance performance. That's equal to flipping a coin, and your specificity is relatively high, but you're missing too many patients with endo. So well, we think, why don't we just increase the threshold and put the threshold at CA125 of 35? But even there, you still see that sensitivity is very low. So there is many patients with endometriosis that are told that they don't have endometriosis. So again, this is not a good test for endometriosis. I think over the last 5 to 10 years, the most attention in the biomarker field for endometriosis has been on circulating microRNAs and also recently on microRNAs in saliva. Why microRNAs? Well, what are these molecules? They are small non-coding RNA molecules. So in the nucleus, from your DNA, there is a transcription to have primary microRNA transcripts. This is then processed to precursor microRNA. It's exported into the cytoplasm. And there it's further processed by dicer and helicase to end up with mature microRNA. So it's a 20 to 30 bases long stretch of single-stranded RNA. This is then included in the RISC RNA-induced silencing complex, so it's a protein RNA complex, where the mature microRNA is, it helps to guide this protein complex to bind with specific messenger RNA targets. And by binding to the messenger RNA is either cleaved and degraded or the repression of translation. So there's a downregulation of gene expression. And we now know from many studies on microRNAs that they play an important role in both the normal physiology and also abnormal, so pathophysiology of diseases and the human body. What makes them interesting from a biomarker point of view is that these small RNA molecules, these microRNAs, are also present in the circulation. And they can be either incorporated into small exosomes and microvesicles, but they can also be attached to high-density lipoproteins or protein complexes. So they are protected from degradation in the blood, so they are relatively stable in circulation, because otherwise most DNA and RNA in the blood is immediately degraded by RNases and DNases, but microRNA is relatively stable. And of course, we hope that our microRNA levels in circulation reflect somehow what is happening at the cellular level. So if there is an abnormal microRNA levels in endometriosis lesions, this could be reflected in circulation. And then this is I realize it's a quite extensive table and a busy slide. It started off with 6 or 7 papers, and now we're up to 19. And I have now a student working on an update of the systematic review, and we have now, I think, more than 23 papers published on circulating microRNAs. And as you can see, many microRNAs have been described as potentially differentially expressed in patients with endometriosis versus controls, but there is very limited overlap between different studies, and there are several explanations for that, which I will focus on in the next slides. So little overlap and sometimes conflicting data. One study, one of the more recent and one of the bigger studies I want to focus on, is a study by Viking Ezenblot from Australia. It's a 4-step study where they had an explorative phase, then a discovery phase, where they then selected certain microRNAs that were interesting, and they tried to validate these findings in an independent patient cohort. And what they found is, as in other studies, that there are some microRNAs, for example here microRNA 141, that are differentially expressed when you compare controls versus patients with endometriosis. So here we see a downregulation of patients with endometriosis. And if you split it up to minimal mild disease versus moderate severe disease, you still see that in both groups there is a downregulation. However, when you try to validate these findings in another cohort, you don't see this downregulation anymore. So this was an incidental finding due to whatever reason we don't understand. When you try to validate these findings, it's no longer present. There is no difference between cases and controls. Another example is microRNA 155. They found a downregulation. So again, microRNA 155 is lower in patients with endometriosis. It's true for both minimal mild disease, moderate severe disease. And it's still true when you look in a validation. So this is an independent validation cohort, and you see very similar findings, on average a lower microRNA 155 level in cases. However, you immediately see that we have the CA125 story all over again. There's not going to be a threshold that is good where you can discriminate cases from control, because if you're going to have a low threshold, you're going to have very few patients where your test is positive. If you're going to have a higher threshold, you're going to tell many patients, many controls, that they have endometriosis. So sensitivity specificity is not good. This is our work that we have published, now 3 years ago, and we are working on follow-up studies where we performed sequencing and qPCR in a large cohort of patients with endometriosis. It's a 2-stage procedure, so we had first 120 patients where we performed the sequencing. We validated our sequencing findings with qPCR in the same cohort, and then we validated our findings in an independent cohort. These were mainly ultrasound negative patients who presented with infertility and pain. And here you see, very similar to what Viking Ezenblot found, that we failed to find any microRNAs that were consistently differentially expressed between the discovery cohort and validation cohort. If you then look at combinations of microRNAs, so we combine 3 microRNAs into small microRNA models, that in black you see the performance of these microRNAs. The area under the curve is quite okay in the discovery cohort. However, when you try to validate your findings, you fail to validate it. So it's difficult to repeat the same experiment or to have the same outcome when you repeat the same experiment in 2 cohorts. These are data from Sarah Mustafa from the group from Hugh Taylor at Yale University. They also did qPCR in serum. They had a discovery phase which was published separately in Fertile Cyril 2016 by Emin Kozar. And then they built models. Again, so they combined microRNAs in a new data set. And then they validated their microRNA models again in the original discovery cohort. So this is actually the same cohort. What was interesting here is that they did manage to validate their findings. So they had a training cohort with a very large area under the curve. That's typical. That's overfitting of your data. That's almost inevitable. When they validated their findings, they had an area under the curve at 93, 94%. So that's very interesting, and we look forward to further data from the group of Yale where they try to do a true independent validation, so in a true independent cohort, and hopefully also a larger cohort, because this was just 48 patients, to see whether the test keeps on performing above the chance performance. This is the study by Elahi Papali from the group of Warren Foster in the US. They worked in plasma, very similar approach, so an explorative study and a validation study, sequencing qPCR based, where they try to validate their initial findings. And again, very similar. So they found some microRNAs that were differentially expressed in the original discovery cohorts. They could validate some of these findings in validation cohort. However, diagnostic performance was not very good. So a lot of overlap. So again, there is no threshold where you have a good discrimination between cases and controls. So in conclusion, can we say, is there a biological link between certain microRNAs and endometriosis? Yes, this is very interesting from pathophysiology point of view. There is a lot of research I didn't mention at the cellular level, so inside lesions, inside the endometrium, where we do see this possible link. So that's plausible, it makes sense. But when we look at it from the biomarker point of view, there is a lot of work to do. Very few studies include validation cohorts. I've only presented the studies that have validation cohorts, and there we see that we struggle to validate initial findings in two cohorts. So there is a lot of variability between different cohorts. There is some overlap. So there are a few microRNAs that keep on popping up in different studies. For example, the LED7 group is found in different studies, so that's interesting, but further research is needed there to find a threshold or a way to get a threshold or a model that helps discriminate cases from controls. So as I said, we have a few potential targets, but there's a lot of work to do. And molecular stability, so although these microRNAs are on a molecular level stable in the blood, it does not exclude variability. Between different cohorts, there is a lot of biological variability. And this is what I want to talk about as well. Where is this variability coming from? As I said, there's a lot of biological variability. And this is by how you define your case. For example, the control group is patients who have a hysterectomy. But in these patients, there is no question whether they have endometriosis, or these are patients who come for tubal ligation. So this is not an ideal control group. Ideally, your control group is also patients that you think they could have endometriosis. That's why you performed a laparoscopy, and it was negative. So you want to do your experiment as it would be in a real life setting. Also, some studies include patients with endometriomas. Some studies exclude patients with endometriomas, deep endometriosis. So I think we need studies with very clearly defined cohorts, both cases and controls, that are clinically relevant. That's one important source of variation. Another source of variability is pre-analytical. How do you collect your samples? How do you process your samples? How do you biobank them? Do you use serum? Do you use plasma? So that's also an important source of variability that needs to be tackled in future studies. And finally, we have analytical variability. This is variability introduced by your analytical method, and I think for microRNAs, we are mainly struggling with normalizing our data. We know that any molecule that is present in circulation is prone to natural variation in concentration. So you need to normalize your data. Most of these platforms are PCR based, so you need a loading control. But there is no housekeeping microRNA in circulation. So we struggle to normalize our data, and that's why you also see that different normalization strategies come up with different results. So there is also a lot of work to do there. That brings me to the future. What can we do in the future? What can you expect from us, the biomarker researchers? I think we need more targeted and focused research. And I would recommend to you all this paper from Sanjay Agarwal in AJOC, where he says, okay, we can have a clinical diagnosis. So it means that we don't have to wait for all these endometriosis patients on biomarkers to solve the problem for all of them. No, for many patients with endometriosis, we can diagnose the disease by ultrasound, and we can start clinical diagnosis, and we can start empirical treatment. For example, today is mainly about ovarian endometriomas. I think there is a need for good skills in ultrasound. All endometriomas can be visualized by ultrasound, and we don't really need a biomarker to find endometriomas. We need good sonographers. And I think I've wrote in one of my papers that a biomarker for endometriomas, it's like a Ferrari. It's very nice to have, but you don't really need it. So if you would ever have one, it would make life easier, but it's not our research priority. So I think we need to look for biomarkers in the subgroups I presented to you earlier, patients with deep endometriosis that can be missed on ultrasound, or patients with peritoneal endometriosis only. And we also need to think like, will we ever find the perfect biomarker, or maybe we should have exclusion tests, likelihood scores. So these are ways that it tells us like this patient is more likely to have endo, more than a black or white story or a binary story, 0 or 1. And I think most of what we do is very complementary and supplementary to one each other. It's not because you have a biomarker that you don't need to do a good medical history anymore or a good clinical examination. And of course you need an ultrasound, you need an MRI. So I think all these investigations and technical examinations can be compatible to one another. And I think we are now slowly evolving to integrate the diagnostic models, especially with the new hype of artificial intelligence, where it's now typically statistically possible to train models on large data sets where you look for very discrete patterns. And I think based on the symptoms, the ultrasound findings that we have and biomarker data, it must be possible to tell certain patients, okay, like you have, based on this model, you have a higher likelihood of endometriosis, so you are a good candidate to have a diagnostic laparoscopy. Or you can say to patients, based on this model, based on your symptoms, the ultrasound and biomarker data, and maybe also patient-reported data, I can tell you with high certainty that you don't have endometriosis, and I don't think it's useful to have a laparoscopy or to have, we can go straight to ART treatment, for example. So that is, I think, what we're looking at in the near future to these integrated models. And I want to show you some preliminary data that we are working on now here at Leuven, where we combined in the cohort that I already presented to you, said, okay, we have our biomarker data. These are ultrasound negative patients, as in there was no hard marker for endometriosis, so there was no cyst, there was no deep lesion, but there could be other soft markers for endometriosis. And we also have clinical data, so symptom data on these patients. And when we combine these markers, none of these markers has standalone a good enough sensitivity or specificity to be clinically useful. But when you combine this, you do see that, and the black line is the original training. The red is when you do an independent validation. Again, you see a drop in performance. That's typical. Your training set is always a bit overfitted. But here you see that we are performing above chance. We have an error in the curve of 65%. I think we can do a lot better if this was a prospective study, because these are retrospective data. So I think slowly we are getting there, that by combining all these data sets, we will be able to tell patients that they have a high or low likelihood of endometriosis. These are some references for the people among you who want to have further reading. And I hope I stayed within my allocated time. Thank you for your attention.
Thank you very much for your excellent speech. Actually, as a biomedical engineer myself, I really thank you for your expertise and for your all explanations that you have made to us. As we told before, we are going to be taking the questions at the end of the section. So I need to just follow up with the second speaker. Thank you again. Our second speaker is Professor David Redwine. He is